From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Welcome to this podcast from JAMA Cardiology. This is Bob Bonow speaking. I'm a professor of cardiology at Northwestern University and editor-in-chief of JAMA Cardiology. We're going to be discussing a interesting and very timely topic regarding assessment of frailty in patients undergoing transcatheter aortic valve replacement. And with me today to discuss this really innovative paper coming out in JAMA Cardiology is Dr. Jonathan Afilalo, who is the Director of Geriatric Cardiology at the Center for Clinical Epidemiology at the Jewish General Hospital in Montreal, where he is also Associate Professor at McGill University. Welcome, Jonathan.
Thank you, Bob. Pleasure to be here and discuss this article with you today.
It really is kind of a step forward because of all the important work that you and others have done in telling us how important it is to identify patients who are very frail, who require aortic valve replacement, surgical or transcatheter, and kind of moving it one step further with some really objective and quantifiable metrics. Perhaps, Jonathan, just to give us a background for all of the listeners, why is frailty an important topic and what's the work that's been done to date in patients undergoing transcatheter aortic valve replacement?
Yeah, so indeed the story began at the onset of the TAVR revolution, we could say, where we were encountering patients with very advanced ages and complex comorbidities. And we had the unmet need of objectifying their resiliency, their functional abilities, and in broader terms, their frailty. And that's where the field really catapulted in the cardiovascular realm to a number of studies that were pivotal in the early days. We focused at the onset on 5-meter gait speed as an objective marker of frailty. And that ended up identifying a subset of older adults who had worse outcomes after these surgical or transcatheter procedures. And from there, we had the idea to launch a multinational study called the Frailty AVR study to go beyond gait speed and to compare and contrast a variety of different clinical frailty markers in their ability to predict not only death, but also disability after these procedures, specifically surgical and transcatheter AVR. And with that study, we built and validated the essential frailty toolset, which combined a measure of lower extremity strength, a measure of cognition, and of course, hemoglobin and albumin into a simple scale to assess frailty. And this has had good traction in the field. It's being used internationally and helping as an initial screening tool for frailty. But one unmet need that I always felt is the need to have some objective biomarkers that could be quantified, perhaps in patients where the questionnaires and physical performance tests were not feasible or were not sufficient. And for me, that launched me into the direction of studying these imaging biomarkers, leveraging the CT scans that we had available in most of these patients, and starting to understand how things like muscle mass and body composition interfaced with the concept of frailty and really provided incremental value. And that brought us to the current paper that we're discussing today.
Yeah, we do want to get into the innards of your study because I think it will be very useful, and we'll discuss why that might be in our evaluation of patients. But do you think in the current way of doing things that many centers are actually doing objective frailty evaluations in patients? The many patients they see who are either undergoing or about to undergo or being considered for a TAVR?
Yeah, it's a good question. At the core, as clinicians, nobody needs to be convinced that frailty is a relevant or important concept for patient-centered decision-making. I think we all feel it, we all see it in our day-to-day practice. The tendency is to want to eyeball assess it because this is quick and intuitive. And often the eyeball test is okay, but often it's not. And we found that our preconceptions as to the eyeball assessment of frailty may misguide us, especially when we associate small, little, older women as being the archetype of frailty. And in fact, what our studies have shown over the years is that it's often the obese diabetics, and others with metabolic phenotypes that are more frail. And that could be just one instance where our eyeball test leads us awry of missing that large segment of the population. So, of course, we do advocate for objective tests to be incorporated. And in certain situations where these tests are mandated, whether through national databases or quality programs, we see better uptake than in other situations. But it's still an uphill battle because it is an extra piece of information that needs to be collected. And it's typically not something that was readily available retrospectively from the EHR until perhaps we entered in the conversation of imaging biomarkers and electronic frailty scores that could start to address that need. But certainly there is room to improve in terms of our uptake of objective frailty testing in day-to-day clinical practice.
Yeah, I'm glad you addressed that because I think we are kind of using the eyeball test. But, thinking of eyeballs, we now have imaging biomarkers that you have been exploring to define a osteosarcopenic phenotype in patients. So let's get into this now because this is really the exciting new work you've done that we're publishing this week in JAMA Cardiology.
Absolutely. So one of the pivotal elements of frailty at the level of body composition is clearly sarcopenia. And our initial work focused on assessing muscle mass from the clinical CT scans and showing how that was predictive of bad outcomes. But there's one major problem with this approach is that sarcopenia not only requires low muscle mass, but also a measure either of low muscle performance or low muscle quality. We can take the famous example of the marathon runners who have low muscle mass, but clearly are not sarcopenic. Their muscles are of very high quality and very high performance. And so there was this discomfort with the initial papers showing a relationship between pure muscle mass and outcomes because we knew that we were perhaps overcalling sarcopenia in some of these patients who had low muscle mass of high quality. And at the same time, probably undercalling sarcopenia in patients who had perhaps more bulky muscles, but muscles that were infiltrated with fat and adipose tissue, as is characteristic of sarcopenic obesity, for example. And therein lies the challenge of not only basing ourselves on muscle mass, but adding ancillary measures to really now pinpoint who is truly sarcopenic, who is truly frail in the physical sense. So the readily available solution would be to say, well, measure muscle performance. So you could measure hand grip strength or quadricep strength, and this would certainly arrive at a better diagnosis of sarcopenia. But again, this requires a whole new piece in our workflow. And we may not be equipped or staffed to get these pieces of information in our day-to-day workflow. So the next measure would be to adopt a measure of muscle quality in parallel to muscle mass. But then again, that is a field or a segment that is perhaps more underdeveloped on the research side, certainly with CT. Most of the muscle quality work has been done with MRI techniques. Although I should say that we are making progress with algorithms to predict muscle quality from CT. And where we had an innovative thought for this paper was to say, well, let's look at bone quality. Because if we're trying to ascertain if this is low muscle mass that is associated with frailty versus more of a healthier low muscle mass, then the bone density should give us a big insight into that differentiation, where low bone density would point us in the direction of saying that this is a phenotype of frailty, and preserved bone density less so. So therein comes the joint concept of osteosarcopenia. We're not the first to think about or conceptualize this, far from it. It's a concept that's well accepted in geriatric medicine and certainly up and coming in the geriatric literature. And it combines those two elements of muscle mass and bone density to arrive at a joint phenotype that is much more closely and specifically linked with frailty than either one alone. And that's what we measured and studied in this article.
So the unique thing here, at least for me as a referring cardiologist to my heart team, is that all of our patients are getting CT scans in preparation for TAVR. And so we have the images. And so as you're pointing out, we can do this with a CT scan. There's no extra work involved, no extra testing needed. And so I think this is a really nice step forward. And then this can be quantitated. So you have quantitative measures of both the psoas muscle area, cross-sectional area, as well as the bone density.
Yes, indeed. Both measures are highly quantitative. And when we initially did the study, we used a semi-automated approach with software tools that enabled us to make the measurements quickly. And since that time, we've made significant progress with deep learning techniques to fully automate these measurements, whereas you do not need anymore to paint or highlight regions of interest. The deep learning models will identify those regions of interest in the skeletal muscle, be it psoas or all skeletal muscle, and also in the vertebral bone to perform these quantifications in a fully automated way. And we and others have been advancing this field of deep learning for body composition and frailty analytics. And we've put our models into a software platform called Core Slicer, which can be accessed online to, again, perform these measurements in an automated way. So whereas things were already pretty easy, as you said, with the scan that's lying around and available to leverage and examine, now the analysis part is even easier and automated with AI.
Okay, so with that background, let's get into the actual data and who the patients were and how the osteopenic phenotype you identified translated into outcomes.
Absolutely. So the first thing to say is that we had 605 patients who were undergoing TAVR. These patients were on average 83 years of age, evenly distributed between males and females. And what we did was we divided the cohort into 4 groups. Either they had normal muscle and bone status, that was the healthy group, so to speak, or they had low bone density alone, low psoas muscle area alone, or both, with the latter group, the both, representing our so-called osteosarcopenic group. The distribution of those was 39% classified as normal bone muscle status, 25% low bone density alone, 21% low psoas muscle area alone, and 15% had osteosarcopenia. That was the distribution of our primary measure of interest. And we were interested to see if this would predict primarily 1-year all-cause mortality, and secondarily 1-year worsening disability, which we defined as accruing 2 or more new disabilities for activities of daily living, or of course, being deceased at the end of the follow-up period. With respect to the outcomes of interest, what we observed was that the 1-year mortality rate was highest in patients with osteosarcopenia. So it was 32%, and then followed by those with low psoas muscle area alone, 14%, low vertebral bone density alone, 11%, and it was the best or lowest in patients with normal bone muscle status at 9%, and that was statistically significant. We went further than that to adjust for covariates that we deemed relevant, things like age, sex, body mass index, TAVI-2 score, Charlson Comorbidity Index, and also subsequently other frailty scales. And at the end of that procedure, we reported that the odds ratio for 1-year all-cause mortality was 3.18. So a tripling of the odds of mortality in patients who had osteosarcopenia, which is a marked effect. And perhaps equally interesting to note is that if there was just low bone density or just low muscle area without the other, where we kind of previously said that there could be questions about the specificity there for a true frailty phenotype, we observed a muted effect of those on prognosis, to the extent that it was really only if both were present that there was an important impact. And so I think that challenges and updates our previous knowledge, which was of muscle mass being a standalone predictor of frailty, to kind of further understanding that we should really have something else along with just purely low muscle mass before we start talking about frailty.
Yeah, I mean, it gets back to your earlier point about muscle mass itself could be not the best indicator. It really depends upon overall health of the individual and whether the muscle mass is a healthy muscle. versus otherwise. A couple of questions then. So suppose you have a patient who you define as being in the high-risk group with true osteosarcopenia. What is the next step? Are some patients then going to be declined for intervention? And we talk about palliative care. Should we be talking about trying to either treat those patients differently, consider cardiac rehabilitation more aggressively? What are your thoughts about actually implementing these new and more definitive quantitative measures?
I would say that it's important to note that frailty is not synonymous with futility. Frailty is highly prevalent, and it's a pre-disability state where we can intervene and improve the patient's outcome in parallel with their cardiac care. This is a model that we've recently presented as a late-breaking clinical trial at the ACC meeting, where we presented the PERFORM TAVR trial for patients with physical frailty and showing how they benefited from an exercise and nutrition intervention to improve their functional outcomes. And I would say that this is applicable to the osteosarcopenia phenotype as well, where identifying osteosarcopenia, sure, it is an incremental risk for the patient's one-year outcome, but I think it is something that we can certainly improve with exercise therapy, nutritional supplementation, and then, as indicated, treatments for building muscle mass and bone density based on approved guidelines. So for me, it's really an opportunity to broaden the care in a more holistic way rather than to refrain from doing procedures. At the end of the day, the procedures are almost above 90-95% technically successful. And what we have to do is support the patient to really derive the maximal functional benefits from the procedure. And that involves treating things like their sarcopenia, treating their osteosarcopenia with interventions that we have already in our armamentarium. And I like to say that in cardiology, we're fortunate to have a subspecialty of cardiac rehabilitation available in most of our centers. And this, to me, is potentially the best treatment we can offer our frail patients in parallel with their cardiac care.
Yeah, thanks for saying that. It's so important in our patients who undergo TAVR, not only because they probably become deconditioned because of their illness, as well as many of them just having frailty regarding to the other factors that you mentioned. Well, that gets into another issue then, because clearly the patients who are most osteosarcopenic, as you mentioned, are older, they have less BMI, and may have other comorbid factors. You did adjust for those, but could there still be some confounding here, but we need to do a little bit more work to really define who these patients are?
There certainly could always be residual confounding, but what reassures me in this case is that it makes good clinical sense. And it's a predictor in terms of osteosarcopenia or even just sarcopenia alone that's been shown in many other fields, in many other disciplines, to be something that is important in the biological aging process, something that is prevalent. And so to me, I'm less concerned about residual confounding than if it were a more esoteric and less biologically rooted predictor. So whether we can continue to refine our characterization of frailty and biological aging for sure, but I don't think that the effect of osteosarcopenia or sarcopenia alone will be washed out by adding new covariates. In support of the construct validity of osteosarcopenia, we did show in this paper that patients with low vertebral bone density were more likely to have vertebral fractures, and also that patients with sarcopenia, low muscle mass, were more likely to have low physical performance battery scores. And so I think in that sense, we can draw lines from these markers towards relevant and patient-oriented surrogates that do matter, and I think, again, reinforce the importance of osteosarcopenia as a true entity rather than just a byproduct or chance finding. So I wanted to just highlight that association because I think it is important.
No, I tend to agree with you, and we had that discussion internally among the editors that here you have a good objective marker. You've done a very good job of trying to adjust as much as one could for all the other factors that are associated with osteosarcopenia. So one final question. The time frame of the study goes from 2012 to 2022. So it's a 10-year period during which there's lots of evolution in TAVR in terms of devices and also patient selection. What are you seeing in terms of the fraction of patients undergoing TAVR now who are truly osteosarcopenic in 2022 compared to 2012?
With respect to the changing landscape of patient profiles in TAVR, we certainly have seen that compared to 2012, the average patient undergoing or being referred for TAVR is less elderly, less frail in general. Although with the increasing absolute number of patients being referred for TAVR, we still have a large critical mass of patients that are in the very advanced ages with complex frailty syndromes and comorbidities. And so I think the relevance is still very much present. It does bring the notion in terms of screening, how screening is now very relevant, because whereas in the past, say in 2012, you could perhaps make a case to do a complete frailty assessment on all TAVR patients referred for consideration, because again, the majority of them were going to be frail. Now, as we're seeing younger and healthier patients referred for TAVR, perhaps we have to be a little bit more judicious in terms of our screening process of doing small or less onerous screening procedures to then zero in with more in-depth assessments on the patients that can benefit the most. And again, that's another point in support of the imaging biomarkers, because the imaging biomarkers do serve as a nice, low-cost, low-effort method to pre-screen patients who could then benefit from the typical questionnaire and physical performance test assessments that we've validated. And I think that still very much have a role in the evaluation of patients. So that imaging could very well be that first step to contribute to the pre-screening of patients who could benefit from deeper assessments, especially now that we have AI tools, as I mentioned, that can automate the process for us and give us a glimpse into frailty.
Yeah, and this now can be assessed, not totally push-button operation, but the machine learning and artificial intelligence can begin to do this in a very objective way. So I'd like to congratulate you, Jonathan, and also your lead author on this manuscript, Pablo Solis-Jerez, for really bringing forward a novel way, and I think an important way that's easily implemented for assessing all of our patients. So thank you for walking us through the journey you've been on in the assessment of frailty in our patients. But I think we should probably come to closure at this point. I'd like to thank Dr. Afilalo for being with us. Also thank our listeners for joining us in this conversation. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.